And we bring a report from the Lewis-Gale Health System in Roanoke, a part of the National HCA hospital system, and a part of the National Capital Division of that national firm called HCA. I'm a member of the board of the hospital. A hospital that has an ideal relationship and somewhat unusual relationship nowadays with its physicians, because 1/2 of the members of the board of the hospital are physicians. And the physicians in the room probably know that in many hospitals, physicians pray to get at least one token physician member of the board of directors of the hospital. 1/2 of our board are physicians. 1/2 of those physicians are private physicians, and 1/2 of those physicians are employed physicians. Rising clinical leaders, where we're encouraged to be involved and to evolve, where we're encouraged to be informed but inform other folks back home, where information told us that we would come and learn cutting-edge content for leadership in an ever-changing environment, and I believe we have. So our project is a little different, but you'll find that it is focused on connection between providers and recipients, and it's focused really on what's very best for the patient. It's focused on outreach.
Our patient group is really patients in rural facilities that require a higher level of care. So a little bit of the background. In 2013, Lewis-Gale Regional Health System implemented a regional transfer center. There are 4 hospitals in our market that we serve, and so, multiple outreach facilities, as I'm sure some of your larger systems do the same. What we found when we started the transfer center was there was friction. We couldn't get anyone to really accept the patient. So you would have a patient in a rural facility who had a tib-fib fracture at 2 a.m. and the ortho said, yeah, give it to the hospitalist. The hospitalist said, I'm not their resident, I'm not doing it. You know, and so that was where we came up with our focus. So our goals were to decrease the number of failed transfers surrounding identifying and accepting provider to less than 2 a month. Increase efficiency in identifying the correct provider up front. You know, for certain specialty groups, we knew it was going to be the hospitalist because they typically don't admit to themselves, which was very difficult for the transfer center nurses to kind of figure out what to do at 2 a.m. You don't want to wake up a bunch of people, but we needed to have the right people involved. So our plan was to obtain an understanding between providers about who would be the responsible party: specialists, transfer center nurses, the ED staff, service line VPs, practice managers, and we thought we would best accomplish this through meetings between the hospitalists and each specialty in separate meetings. This is a summary of our guideline agreements for cardiology. They were very reluctant to make any agreements. We did get them to say that cardiology would always accept STEMIs requiring intervention, and they would always accept any complications related to the cardiology interventions that they had done. But that was about it. Everything else, we're still paging the hospital.